Praise be to Allah, the cherisher and sustainer of the worlds. I'm Dr. Ramsha Mushtaq Khan, and today I have the opportunity to present on the topic Nutritional Programs in Pakistan under the kind supervision of Professor Dr. Saira Afzal. Quote of the day: A healthy outside starts from the inside. Content outline: Introduction to nutritional programs, national level nutritional programs, integration and management of nutritional programs, and recent advances in multiple choice questions. At the end of this presentation, participants will be able to appreciate the historical development and current state of nutritional programs in Pakistan, identify and describe the different national level nutritional programs, including their aims, targets, demographics, and geographic focus, explain the integration and management of processes of these programs, emphasizing the importance of cross-sectional collaboration, discuss the recent global advances, and answer multiple choice questions. For a brief background, the World Health Organization envisions a world free of all forms of malnutrition where all people achieve health and well being. Effective nutrition policies and actions exist but are often inadequate in the face of the complexity of the double burden of malnutrition, wasting, stunting, low birth weight, and micronutrient deficiencies on one hand, and overweight, obesity, and diet related non communicable diseases on the other hand. The goal of nutrition education is to reinforce specific nutrition related practices or behaviors to change habits that contribute to poor health. This is done by creating motivation for change among people to establish desirable food and nutrition behavior for the promotion and protection of good health. This is the two types of malnutrition, undernutrition, kwashiorkor and marasmus. Community-based food and nutrition programs have been implemented in many countries. They have in common nutrition and nutrition-related objectives, be it the broad objectives of reducing the prevalence of malnutrition or improving household food security, or more specific objectives related to a single micronutrient or a single nutrient activity such as the promotion of breastfeeding. There are now a number of successful programs, and a close examination and analysis of these programs can help us understand the process of achieving success. Community-based nutrition programs. Evidence demonstrates that with careful design and phased implementation of different components, nutrition activities can enhance positive socio-political factors, thereby creating a positive context for the nutrition programs and for capacity building for the broader challenge of social development. Community-based nutrition programs generally include activities such as growth monitoring, breastfeeding promotion, nutrition education, promotion of better weaning practices, micronutrient programs, and deworming. Success in these programs involves the attainment of objectives related to process, outcome, and sustainability, which is financial and functional, all of which are influenced by socio-political, technical, and financial factors. Four well-known programs generally acknowledged as successful are used to illustrate the combination of contextual, socio-political, programmatic, technical, and financial factors that ensure success in community-based nutrition programs. The more technical programs are more instructive and replicable given the difficulty in creating conducive socio-political factors. The national programs in Pakistan include school health programs, micronutrient initiative program, family planning, primary health care program, and Tawana Pakistan project. This is some about the nutrition history in Pakistan. The government of Pakistan has begun to place increasing policy focus on nutrition and food security. Despite periods of high growth, Pakistan failed to achieve commensurate reductions in the prevalence of undernutrition, stunting among children, and child mortality. To accelerate progress in these areas, Pakistan joined the international Scaling Up Nutrition movement, set up sustainable development goals, monitoring units, and has developed multi-sectoral nutrition strategies in each province. Nutrition historically has been a low priority area in Pakistan with low visibility from the political leadership. Pakistan renewed its pledge to improve health outcomes of the population when it signed the World Health Organization's Alma Ata Declaration in 1978, which laid the foundations for health for all by the year 2000. More than a decade later, the government of Pakistan launched its first national health policy in 1990. The policy focused on school health services, family planning, nutrition programs, sanitation, safe drinking water, and control of communicable diseases. After devolution post-amendment, with the approval of 18th Amendment, with the approval of 18th Amendment to the Constitution, 17 ministries from the center were devolved to provinces, thereby increasing the autonomy. Funding increased to Punjab, Sindh, Khyber Pakhtunkhwa, and Balochistan, which enabled the development partners' direct engagement with the implementers to spearhead nutrition as a new public policy agenda. Post 18th Amendment, the provincial governments decided to steer the health sector through independent strategies. These strategies were developed in response to challenges to the quality of service delivery and coverage. Focus on key strategic areas included an integrated approach through essential health services packages at all levels, contracting out of services, development of multi-sectoral nutrition strategies, restructuring of the Department of Health and regulation of public and private hospitals were emphasized. The nutrition wing shifted to the Planning Commission and was financed through the development budget of the Commission post-devolution, which was a challenge since it was not an implementing agency. While there was much greater recognition of nutrition issues post-devolution, the progress was impeded by the lack of coordination, with no single institute responsible for nutrition at the federal level. These floods of 2010 and 11, along with the findings of National Nutrition Survey, drew attention to the dismal state of maternal and child undernutrition. This led to the collaborative efforts by UN partners towards community management of acute malnutrition (CMAM) all over Pakistan to screen and alleviate children suffering from moderate acute malnutrition and severe acute malnutrition. Training was provided on screening and management of SAM and MAM cases, followed by a referral of those with severe complications. Supplies and equipment, such as those needed for anthropometric measurements and stabilizing centers, were provided by UNICEF, while ready-to-use therapeutic food, antibiotics, and other emergency care medicines were also arranged. With this visibility in the media and among political stakeholders, the need to develop framework to guide nutrition efforts to address undernutrition became necessary. The Pakistan Integrated Nutrition Survey was developed in 2011 to facilitate cross-sectional action on nutrition, contrary to the previous practice of confining it to the health department. Pakistan Integrated Nutrition Strategy was then used as a strategic framework to guide provinces to define nutrition in their provincial post-devolution development agendas. On the international front, Pakistan also became a signatory to the Scaling Up Nutrition movement in 2013. Policies and programs designed for impacting nutrition outcomes. With respect to policies directly impacting nutrition status, breastfeeding, salt iodization, and food fortification efforts have also been woven into the historical context of nutrition within Pakistan. Food fortification efforts towards setting food standards began with the passage of Western Pakistan Pure Food Ordinance in 1960 to safeguard consumers' health through provision of quality food items which would be free of all kinds of adulterations. This was followed by mandatory food fortification legislation of vegetable oil under the Pakistan Pure Food Rules of 1965, as fortification was one of the most cost-effective solutions to address chronic micronutrient deficiencies without requiring changes in the eating habits. Salt iodization. Salt iodization initiatives began as early as 1971 when a salt iodization plant was installed in Skardu, followed by another one in Peshawar in 1975 as the clinical cases of goiter became more prevalent, especially in KP and FATA. The National Iodine Deficiency Disorder Control Program was initiated in 1989 with support from UNICEF. The government of Pakistan provided financial and logistical support to private salt processors of iodized salt and to establish an iodine supplementation support facility at the federal level. In 2001, the Nutrition Division developed a semi-quantitative rapid testing kit for use in surveys and in process quality control of iodized salt. The Universal Salt Iodization Program, which was initiated by the Nutrition Wing of the Ministry of Health with technical and financial support of the Phase 1 of the program was launched in 2006 as a pilot in 20 districts called the salt iodization model districts, where salt iodization reached over 90% of the population. The World Food Program and MI joined hands in July 2006 to expand the program in phase 2 to 29 districts in KP, HAK, Gilgit-Baltistan, and FATA at high risk of iodine deficiency. Breastfeeding and child nutrition. The Protection of Breastfeeding and Child Nutrition Ordinance became official in 2002 with the purpose of raising exclusive breastfeeding rates in the country. In 2009, the MOH notified the protection of breastfeeding rules at the National Infant Feeding Board to monitor implementation, which came into existence in 2010. After several years of delay in 2015 in Pakistan, along with its development partners, also finalized the much needed national strategy on infant and young child feeding practices for 2016 to 2020. Through its various plans, programs, and policies, the government of Pakistan has managed to bring nutrition into the political stream by making it part of the Pakistan Vision to 2025 under Pillar 4. In the post-revolution context, cross-sectoral dialogues about nutrition have begun in each of the provinces led by the Planning Commission and technically supported by development partners. Whilst momentum has been built, must be sharpened and sustained. The government has consistently noted its commitment to the goal of achieving food security and adequate nutrition all its people, even if sometimes its achievements and efforts may have fallen short of its commitments. The very nature of nutrition does not offer quick short-term wins, but instead relies on a cohesive development vision that has been forthcoming. Integrated Reproductive Maternal Newborn Child Health and Nutrition Program. This program is inspired by the desire of the government to reduce maternal, newborn, and child morbidity and mortality, promote family planning services, and improve nutritional status of women and children. The program contributes to the all health and nutrition sectoral priorities set in the economic growth framework of the Planning Commission, that is, revamping management of primary, secondary, and tertiary healthcare financing reforms, governance reforms in health sector, especially setting quality standards, essential services packages, AIDS effectiveness, service structure, capacity, and access to affordable medicine. The healthcare programs are designed to enhance the quality of life and facilitate the citizens to meet their healthcare needs. These programs also educate physicians and other health professionals. Under the healthcare programs, some initiated programs include the School Health and Nutrition Program. School health and nutrition program. School health services remain a component of health service delivery. This service became dormant in late 80s. Under the health sectoral reforms, it was perceived that there is a dire need of health and nutrition program for the school children studying in rural areas. This program can contribute to improve health, nutrition, learning performance, increase school enrollment, attendance, better hygiene practices in the community, and to achieve the Millennium Development Goals for health, education, and child protection. Hygiene education appears in the commitments of governments as well as international agencies and are relevant to the international charters like Millennium Development Goals and others. Keeping in view the importance of the intervention, Punjab Health Sector Reform Project, in partnership with UNICEF and other development partners, initiated school health program in 2009. The staff was trained with support of the UNICEF. The objectives included screening of the primary and middle school children for detection of common health problems by general physical examination and examination of eye, ENT, dental. Bring about an improvement in the general quality of life of school children, capacity building of school teachers for screening of children and promotion of hygiene education among the school children. Identification of problems after screening and referral of student to BHUs, RHCs, THQs, DHQs, and tertiary care hospital if required. Linkage with community, with the students playing catalytic role for dissemination of environmental sanitation and hygiene education, such as agent change. Implementation partners include Punjab Health Sector Reforms Program, Health Department, Education Department, district governments, and UNICEF. The nutrition interventions of Tawana, Pakistan project. Nutrition interventions include deworming drugs, noon meal, micronutrient supplements including iron, iodine, and vitamin A. Benefits to schoolgirls: improve nutrition status, prevents infections and nutritional deficiency diseases, and improve school enrollment and performance. This is the school health program chart employed in Pakistan by the National Commission for Health Development. Punjab Food Authority, the Punjab Food Authority has been working as a functional entity in Punjab province across all 36 districts since July 2012. Specialized wings, technical and operations which are functional and working to enforce the food hygiene and quality standards. Punjab Food Authority have state-of-the-art labs working throughout the clock, which carry out the food testing for food hygiene and food adulteration under the supervision of the qualified staff. The Punjab Food Authority proposes the amendments in nutrition topics consists of 7 sections for the official website of PFA so that people can have access to the authentic information conveniently and to target the maximum audience to have awareness regarding food consumption and health. These sections include general nutrition knowledge to devise and implement meal plans that improve the individual's and family's nutrition. The Punjab Food Authority has taken bewildered gesture to create the interactive timeline full of information. The idea of incorporating these sections is to maintain good nutritional status, correct deficiencies and diseases, if any, and make changes in lifestyle when necessary for general public regardless of region. The Punjab Food Authority wants to make every possible effort for general public to have approachable knowledge and be able to access nutrition awareness data in just a single click. This is the integration of essential nutrition interventions into primary healthcare in Pakistan to prevent and treat wasting. What we know is child wasting levels remain extremely high in Pakistan, and coverage of wasting treatment services is low. Community-based management of acute malnutrition was first implemented in Pakistan in 2005. Later on, the government of Pakistan developed national CMAM guidelines used to guide CMAM community programming in priority districts, co-funding by government of Pakistan and external partners from 2011 and onwards. Now, mainstreaming nutrition-specific interventions into primary healthcare services. The challenges include a fragmented information system, weak supply and logistics management, and a reliance on short-term funding grants, resulting in a lack of sustainability. Program coverage, therefore, remained limited. In 2019, around 265,000 children were treated countrywide for severe acute malnutrition, and 157,000 children were treated for moderate acute malnutrition, with an overall coverage of around 5%. CMAM continued to be implemented as a vertical program located under the same roof as health services within each province, but with separate staff, management staff, and a separate cadre of nutrition assistants, supply chain, and information management system not integrated within existing government systems. Evolution of approaches to wasting treatment in Pakistan, inclusion of selected nutrition-specific interventions into the routine package of services delivery at the primary healthcare level. Minimum essential nutrition package, which includes wasting treatment services and key prevention and promotion services, including infant, young child feeding counseling, vitamin A supplementation, deworming, and multiple micronutrient supplementation (MMS) for children and pregnant and lactating women, would become part of the universal health benefits package delivered routinely through the government health system by the existing health workforce. Advocacy for the allocation of the necessary resources to implement the management of wasting at scale in Pakistan through the primary healthcare system. Development of workforce capacities, integration into government supply chain and information systems, local production of lipid-based specialized nutrition supplements, ready-to-use therapeutic foods, and ready-to-use supplementary foods for the treatment of moderate acute malnutrition and severe acute malnutrition are now at advanced stages of production and are being used in the implementation of CMAM programming institutional arrangements. Work has been ongoing for several years to transition nutrition programming in Pakistan from emergency-driven vertical programming to a systematic developmental approach to address malnutrition through the primary healthcare system. Continuous advocacy and sensitization of policymakers have driven change towards the full nationwide integration of nutrition services into the primary healthcare system. While accepted at the policy level, these changes are yet to be rolled out in practice. The next immediate step is to add wasting management to the health function of the government's 5-year plans, 2018 to 2022, and National Action Plan from 2019 to 2023, and to advocate for the allocation of adequate financial resources based on the nutrition investment case to implement the minimum essential package of nutrition services. This government led approach is key to enabling full coverage of wasting prevention and treatment services to meet national wasting reduction targets. The the government of Pakistan partners with World Food Program and Micronutrient Initiative to address micronutrient deficiencies. This is another initiative. Launched in September 2016, the funded food fortification program plans to cut iron deficiency anemia by a third and vitamin A deficiency by a quarter in women and children by fortifying flour, ghee, and edible oils. It cooperates with the Pakistani government on the technical standards, regulations, and lab testing infrastructure, subsidizing mills in terms of premix costs as an incentive for millers to produce fortified flour. Food fortification program. Fortification is the practice of deliberately increasing the content of an essential micronutrient, that is, vitamins and minerals, in a food so as to improve the nutritional quality of the food supply and provide a public health benefit with minimal risk to health. Family Planning and Primary Healthcare Program. The National Program for Family Planning and Primary Healthcare was launched in 1994. It is one of the largest community-based programs in the world, providing primary healthcare services to about 80 million people, most of which is rural poor. Now it's time for the recent updates. Nearly 10 million Pakistani children suffer from stunting. Only 38% of children are exclusively breastfed for the first 6 months of life. As a result, more than half of the children under 5 years of age are deficient in vitamin A, 40% are deficient in both zinc and vitamin D, and nearly 62% are anemic. 8 out of 10 Pakistani children do not eat right type and quantity of food. The solution: UNICEF works in nutrition is supporting our mandate to protect child's right, in particular to the right to the adequate nutrition, as well as the children's right to develop their full potential. Pregnant women need a diverse, rich diet in vitamins and minerals, though it is rarely the case in Pakistan. Nutrition and food safety. Malnutrition in Pakistan is a complex multi-sectoral problem that presets across a continuum of poor nutrition, from undernutrition due to deficiencies in energy, protein, and micronutrients to problems of overweight, obesity, and non-communicable diseases resulting from poor quality, energy-dense, and micronutrient poor diets and low physical activity. Tracking progress on nutrition policies, programs, and outcomes in Pakistan. The World Health Organization and other global nutrition and health agencies recommend nutrition actions throughout the life course to address malnutrition in all its forms. Now, the Pakistan Multi-Sectoral Nutrition Strategy 2018 to 2025. The national strategy highlights main objectives as number one, align provincial programs to harmonize provincial objectives with the national goals. Number two, coordinate provincial program design and implementation to create economies of scale in capacity building, procurement, logistics, monitoring, and evaluation. Number three, open channels and develop synergies among provincial programs to facilitate scaling up interventions on national scale. And number four, optimize contributions of federal technical institutions with unique capacities or mandates regarding product standards and laboratory analysis. Now it's time for the multiple choice questions. Number one, a public health team visited the community and found that the prevalence of underweight children under the age of 5 had increased over the last 5 years. In order to lower the prevalence of underweight in this community, the following nutrition program must be implemented. A. Community HIV prevention and care program. B. Community immunization program. C. Community viral hepatitis prevention and care program. D. Community water fluoridation program. And E. Community-based nutrition programs.
E.
Yes, the answer is E. During health and growth parameter monitoring, if a child's height for age in an XY school is more than 2 standard deviations below the median height for age of the WHO child growth standards, the child should be classified as A. Kwashiorkor, B. Normal growth, C. Obese, D. Protein energy malnutrition, and E. Stunting.
E.
Yes, the answer is E. A 7-year-old daughter visited the doctor with the complaints of fatigued attitude. Mother also mentioned her weight gain and hair thinning as well as constipation. She also has a problem with the dry skin. What kind of deficiency is most likely to induce these symptoms? A. Chromium, B. Copper, C. Iodine, D. Iron, and E. Zinc.
C.
The answer
C.
yes, the answer is C. A study found that the success of a community-based nutrition activities is dependent on careful planning and phased execution of power arrangements and social connections affecting nutrition programs and influence of society's decision to launch or support such programs. In this situation, the factor responsible for the effectiveness of the community-based nutrition efforts are A. Economic factors, B. Financial, C. Political, D. Socio-political, and E. Technical factors. The answer is D. Socio-political factors. Food fortification program has been launched in a community for addressing micronutrient deficiencies in women and children. Food fortification is defined as A. Adding flavors in a packed food. B. Coloring of foods to look fresh. E. Increasing the content of one or more micronutrients. Removing the beneficial substances from food. And E. Adding harmful substances from food.
C.
Yes, the answer.
C.
Yes, the most common health screenings in schools are done in collaboration with the local public health department. Which of the following is not done on a regular basis in school health programs? A. Blood reports. B. Sputum spear microscopy. C. Dental health screening. D. Ear checkup, and E. Eye check.
B.
Yes, the answer is B. A 39 years old female patient presented an outdoor department with a 5-month-old daughter who is only on breastfeed. She wants to know about the diet requirement of the baby at this age because the baby weight is low for her age. Regarding a situation, best plan for her is um, breast milk alone is enough for 4 years. Breast milk alone with formula milk should be given. Continue breastfeed for 2 years and weaning should begin after 6 months. Only solid food should be given after 6 months and weaning of food should be started after 8 months.
C.
C.
Yes. Yes, the answer is C. In Pakistan, child wasting remains extremely high and wasting treatment services are neglected. Integration of important nutrition treatments into which level healthcare level is required? A. Primary, B. Private sector, C. Provincial department, D. Secondary healthcare, and E. Tertiary healthcare.
A.
E.
Yes, the answer is A. Acute starvation has the catastrophic effect of wasting, literally wasting away to skin and bones. Wasting is particularly prevalent in Pakistan, with certain areas of the country regarded to be in a state of emergency wasting. In Pakistan, how much out of 10 children do not consume proper type and amount of food? A2, B4, C5, D8, and E9.
2.
C.
8. The answer is D. A bottle for 10-month-old irritable child presents to the emergency department complaining of failure to thrive, persistent diarrhea, and loss of subcutaneous fat. Which is the most likely diagnosis? A. Kwashiorkor, B. Marasmus, C. Vitamin A deficiency, D. Vitamin C deficiency, and E. Vitamin D deficiency.
A.
The answer is B.
Marasmus.
Yes. This is the key of the MCQs, and this is the link to the YouTube channel. And thank you very much.